Very good morning, everyone. Welcome yet again for another masterclass. This is the fifth masterclass in this series. And in this masterclasses, we are discussing the clinical case discussion on important clinical topics. So this is the fifth in this series. Last week, we discussed patients with different disorder. Today, we discuss about the patient who comes with recurrent jaundice. All of us know that a number of patients in outpatients do come to us with the symptoms of recurrent jaundice. And how do you approach? Recurrent jaundice could be intrahepatic, extrahepatic, and there are a number of causes of that. Yeah. What is the ideal clinical way to approach these patients? And for that, we have total environment.
Govind, you need to unmute yourself.
Sorry. Very good morning, everyone. Very good morning, everyone. Welcome to the fifth masterclass of AIH. The second phase of masterclass, we are talking about a clinical case discussion on various topics. This is the fifth in the series. Today, we will discuss about patient with recurrent jaundice. How do you approach them, and how do we reach to a diagnosis in a most appropriate way? To discuss this case, we have three very eminent faculty. Dr. Anup Saraya. Anup Saraya is the professor of gastroenterology at and head of gastroenterology at All India Institute of Medical Sciences, my alma mater. Dr. Setu Babu. Setu Babu is at KIMS Hospital. He's one of the very senior gastroenterologist and very good teacher. Had a lot of interest in teaching the medical students. And we have Dr. Ajay Duseja, who is a professor of hepatology at PGI Chandigarh. We have Dr. Sunil Khandeja, again additional professor at PGI Chandigarh. He will facilitate the case. He will run through the slides and put forth questions. At the end of it, summarize the approach to patient with recurrent jaundice. Along with that, we have two participants, and I'll request Dr. Ajay. Both participants are from PGI Chandigarh. May I request Dr. Ajay to introduce to them, and I hand over this proceedings to all the three faculty and Dr. Taneja and two of the trainees in hepatology.
Yeah, thank you, Dr. Govind. I think at the outset, my sincere thanks to ISG, especially Dr. Makharia, for giving us this opportunity. So what we have planned is that we have planned two cases of recurrent jaundice. First case would be what we call the long case, can go on for an hour or so. And the second case would be a short case and maybe for half an hour or so, since we have 1.5 isn't total with us. And for presenting these two cases, I think we have two of our DM residents, DM hepatology residents from our department, Dr. Akash Gandotra and Dr. Amandeep Singh. And so they would be alternating and presenting the history, exam, investigations and all. So with the permission of Dr. Saraya and Dr. Setu Babu, can we request one of them to start the case?
Yes.
Yeah. So maybe Dr. Akash, you could start with the first case. And Dr. Taneja, can you please share the slides and we can go ahead.
Good morning, everyone. So for the first case, we have Ms. R, with 17-year-old female, resident of Sirmaur, Himachal Pradesh, and a 12th standard student. She presented to us with the chief complaints of recurrent jaundice for the past 3 years. So in the background history, the first episode was in 2011 when she developed yellowish discoloration of eyes, which was associated with high colored urine. It was noticed by her family members. There was no history of fever, nausea, vomiting at that time. There was no history of jaundice in the family or clustering of cases in a locality. There was no history of pruritus or clay-colored stools. She was managed at a local center at the time, of which no records are available. She improved gradually and remained asymptomatic for the next 1 year. She had a similar episode in 2013, which was again managed in the periphery, of which no records are available, and she improved gradually. So this time she presented to us with the similar episode of jaundice associated with high colored urine for the last 1 month. She had no history of fever, pain abdomen, distension, black teddy stools, hematemesis, any history of complementary or alternated medicine intake, or altered sensorium. There was no history of ecchymosis, recent vaccination, loss of appetite or weight. There were no history of any joint pains, myalgias, oral ulcers, dysarthria, tremors, any blood transfusions, or any tattooing history, or there was history of any high-risk sexual behavior also.
So, okay, I think so. This is a poll question, so maybe the admin can do that. Yeah. Okay, I think we can stop here at 30 seconds. So the question was that all are the causes of conjugated hyperbilirubinemia except. So the 93% of the people have answered correctly, which is hemolytic jaundice. So hemolysis will cause, unconjugated hyperbilirubinemia, whereas the other liver diseases would cause conjugated hyperbilirubinemia. And from the history, I think this lady or young girl, Kash, what do you think? She had conjugated hyperbilirubinemia or unconjugated, the way she presented?
But based on history, she had jaundice along with high colored urine.
Right.
So it's predominantly conjugated hyperbilirubinemia.
Okay, so you will think more of conjugated hyperbilirubinemia. Can you have little high color urine in some causes where it is predominantly unconjugated?
Yes, sir, we can have high colored urine. For example, in Gilbert syndrome, some patients do complain of high colored urine, but that is more with fasting, and as the day improves or as they drink more of water, the urine clears.
Right. Okay. So there could be a diurnal variation. So early morning, sometimes they do complain, but if it is remaining all throughout, it's predominantly tells us it's a conjugated hyperbulimia. So this girl seems to have a conjugated hyperbulimia. So I think we can move ahead. As I said, 93% have answered it correctly. So let's go further. Dr. Setu Babu, Dr. Saraya, any question at this stage?
I just wanted to also explore the possibility of dual options, like somebody who's got hemolysis with an autoimmune, just to think like a postgraduate. Keep an option open.
Sure.
Yes.
So we can move ahead. Yeah.
So in the past history, she had no history of diabetes, mellitus, tuberculosis, hypertension, asthma, or any surgery or chronic medication in the past. In the personal history, she attained menarche at the age of 13 years with regular cycles and normal flow. She consumes a mixed diet with 2000 kilocalories per day. There are no addictions. She has a satisfactory and academic performance in school, and she belongs to upper middle class as per the modified Kupuswamy scale. Family history: she's a child born to non-consanguineous marriage with 2 siblings. Both are healthy. There is no history of any similar illness in the family. Her father and mother are both healthy. So to summarize my case, she's a 17-year-old female with recurrent episodes of non-cholestatic jaundice with no prodromal symptoms for past 3 years, with no history suggestive of liver decompensation.
Okay, I think maybe, yeah, we can have a poll question here from the audience, and then we will ask Akash to give what are his possibilities based on the history. So the poll question is that based on history, which is the least likely diagnosis, least likely out of the 4 choices: AIH, chronic Hep B, Wilson's, and hemolytic anemia.
Hello.
Okay, I think we can stop it because 30 seconds gone. So again, 62% of people have voted for again hemolytic anemia, which is the least likely, which I think majority have voted it correctly. But again, 30% have also voted in for chronic Hep B, which they think is least likely, and 6% and 2% respectively have voted for Wilson's and autoimmune hepatitis. Dr. Saraya, Dr. Setu Babu, any thoughts on this? Dr. Setu Babu, you need to unmute yourself.
Can you think of a primary sclerosing cholangitis a presentation 1-2 episodes? Because that's more common than, for example, autoimmune hepatitis Wilson's or less common. PSC could be slightly more common. I don't know your comment also on that.
Akash, what are your thoughts on that? I mean, go back. What are your thoughts? I mean, the question, can you answer this? Are you thinking of PSC here? Can you think of PSC?
No, sir, I've not kept the possibility of PSC because first of all, she is a female and we see more patients of PSC in male patients. And sir, recurrent episodes with spontaneous resolution of jaundice would again.
No, Akash, that could happen, but the only thing is it's a non-cholestatic presentation.
Yes.
No, PSC is a cause of, cholestatic jaundice. So most of them would come with, features of cholestasis. Here we are talking of a non-cholestatic, right? So yes, PSC would always be a differential, somebody coming with recurrent young male, commonly yes, but young female also. But then you can keep that as a possibility, maybe low down because it's a non-cholestatic. But you can't really exclude that based on the history. Yeah.
Ajay, can I make a small comment out?
Yeah, sure, please come. Yeah.
Akash and all others, that gender-based diagnosis in a single given patient may not be appropriate unless occurs exactly only in females or male. We are not talking of 100 patients in the clinical outpatient or inpatient. We talk of a single patient where we do know that the PSC does occur in a lot of men patients. So therefore, ruling out just men being men or women may not always be right. So maybe probably we don't emphasize too much on the gender on these issues.
Defense. Actually, it's a defense actually.
Yes. So can we, Akash, now can we request you to tell us your possibilities based on the history? What are your possibilities based on the history?
Sir, based on the history.
And Akash, sorry, you need to tell us the possibilities and maybe points in favor and against each possibility, right? Okay.
Yes, sir. So based on the history, this looks like to be a hepatocellular origin of jaundice, predominantly non-cholestatic. So I would like to keep my first possibility as autoimmune hepatitis. And points in favor of autoimmune hepatitis would be a young age with a female gender with multiple episodes of non-cholestatic jaundice with no history of any prodromal symptoms. So I would like to keep that as my first possibility. But spontaneous resolution without any treatment and sir, recurrent episodes every year would be a soft pointer against autoimmune hepatitis.
So let me stop you here. So how common is the acute presentation of autoimmune hepatitis? Because she has always presented like an acute hepatitic illness, you said, right? And it is number one. And secondly, how common is this recurrent acute presentation with AIH?
Sir, around 25% of the patients of AIH presents as acute hepatitic illness. And sir, for the second question, I could not find any data on recurrent episodes of AIH, any patients or any case series or any case reports of.
Okay, Dr. Setu Babu, please. Yeah.
There is one more clinical spectrum which all of us should learn is the first episode could be an acute viral hepatitis that precipitates an autoimmune as another phenomenon which we need to know. For example, Hep E, the first presentation. Then subsequently, the autoimmune gets precipitated and it will present autoimmune. This is just to know the clinical spectrum. Real-time practice is slightly different from laptop-based presentation, but you should also know this entity clearly. I hope Ajay.
And Akash, what are the points which goes against the diagnosis of recurrent means AIH at this stage?
Sir, spontaneous resolution without any treatment and sir, no other history of any other concomitant autoimmune diseases
How frequently AIH present with jaundice? What is the commonest presentation of AIH?
So commonly the patients will present with transaminitis, and they can have concomitant jaundice as well. Usually the acute hepatic illness, they will present as acute hepatic illness with raised liver enzymes and high bilirubin. Sir.
I think fatigue and arthralgia, these are two important features. Presenting fatigue and arthralgia. And fatigue and arthralgia is not there, it is jaundice.
Right. And Akash, you yourself said the acute presentation is only in 20-25%, right? So most of the patients will come as what we call the chronic hepatitis. They may not come with jaundice. It's only the symptoms like fatigue, arthralgia, and other symptoms. And then on investigations, they are found to have raised enzymes, positive autoimmune markers. So that's the commonest presentation. So this is not a very common, but yes, acute presentation can happen in around 20-25%. So what is, how about your second and third possibilities? Can you tell us the points in favor and against?
Sir, I've kept chronic hepatitis B.
So, okay, this was your discussion. Okay, fine. Tell us.
Sir, I've kept chronic hepatitis B with flares as my second possibility. And sir, the points in favor of chronic hepatitis B would be her young age. I'm presuming that she had a perinatal infection, and now she has presented with chronic hepatitis B with acute hepatic flares. And since we are in the intermediate endemic zone, so that makes it more likely. And but sir, most of these patients, around 30-40% of the patients, can present with acute hepatic-like illness with the flares, with more than 5 times of ALT rise. But usually these patients have concomitant decompensations along with it, which was not present in the index case. So that would go against the possibility of chronic hepatitis B, sir.
So I think the question again would be, how common are the spontaneous flares? Because she has had these spontaneous flares. I'm pretty sure she was not on any kind of drug which could, induce a flare in her. So that would be the first question. And the second question, which you have already said yourself, how common when the flares happen, how common are the icteric flares in comparison to, anecteric flares?
Sir, around 30-40% patients presents with spontaneous flares in chronic hep B, and most of the time these are anecteric flares with just the abrupt rise of ALT of more than 5 times. But icteric presentation can be there in around 5-15% patients.
Okay, Dr. Setu Babu and Dr. Saraya. Yeah, please.
For a minute, suppose I remove the cholestatic and patient is cholestatic. Could you add 2 or 3 causes? Just I want to know how many, For example, are you thinking of a PFIC type 3 or something like that? Could you think of if cholestasis were to be there?
Sir, if cholestasis comes in the picture, so I would like to keep PSC as one of the possibilities. Then PFIC 3, yes, PFIC 3 would be one of the possibilities, sir.
Akash, PFIC 3 will you keep if the cholestasis is there, or BRIC you will keep?
Or BRIC.
BRIC is the probably a better.
PFIC, by definition, is a progressive disorder. So once somebody has a jaundice, they can get into liver failure progressive. Whereas BRIC can, continue to happen recurrently.
BRIC is a better thing.
Yes. BRIC would be a better possibility.
Yes.
So out of all the PFICs, PFIC 3 can happen in adults. And we know PFIC 1 and 2 would happen in, neonates or children. Yeah, right. Okay, fine. So can you go to the third possibility? Why did you keep Wilson as the possibility in this patient?
Sir, because of the young age, I have kept lower down the possibility of Wilson's, although I could not find any neurological symptoms and sir, recurrent episodes with spontaneous resolution that goes against the possibility of Wilson's. But low down the order, sir, I've kept Wilson's because of the young age.
What is the clinical setting when Wilson can come with, recurrent jaundice? What causes this recurrent jaundice? Wilson again can come as chronic hepatitis, acute hepatitis, cirrhosis, right? All that. So when do they come as recurrent jaundice?
Sir, Wilson's disease has associated hemolytic anemia. So at that time, they can present with recurrent jaundice.
So will they have, again, I think we have discussed earlier, conjugated hyperbilinemia versus unconjugated. So will they present like, and if she was hemolyzing, you would have expected, some other features of hemolysis, features of anemia, and the urine may not have been high colored, right? So it's
Yes.
probably not the recurrent hemolysis which is happening. So it is something else. So still, would you like to keep the possibility of Wilson's?
Sir, on the basis of history, I will still keep my possibility, but low down the order, sir.
Dr. Setu Babu, Dr. Saraya?
You did mention hemolysis. What is your clinical evidence of hemolysis?
Sir, patient will have.
No. Here you mentioned hemolysis. We want to talk only about this case. I will not be impressed with your theory in the real-time exam. So, what is your evidence of hemolysis to say? That's very difficult. When here you are thinking of autoimmune with hemolysis, or baseline something, and then you are adding hemolysis, or Wilson's progressive. What will be the clinical evidence of hemolysis in the absence of liver disease, in the presence of liver disease? For example, somebody who's got recurrent jaundice with an almost near normal stool, or sometimes high coca-colored stool, both can happen. And cholestasis is uncommon in hemolysis, and the eye color is altogether different, and they'll have less of conjunctival pigmentation. So I think these things you need to look at when you talk about clinical hemolysis. Make a note on clinical hemolysis with liver disease, clinical hemolysis without liver disease.
So I think that's okay. Maybe we can also take some questions from the chat box here. People are commenting. Are you considering Gilbert syndrome here?
No, sir.
There is a question in the chat box. How do you respond to that?
Sir, Gilbert usually presents with unconjugated hyperbilirubinemia, and usually, sir, that is not the case in that is not the presentation in our index case. Which predominantly this patient had high colored urine that suggests conjugated hyperbilirubinemia. So I have not kept Gilbert as my possibilities.
And again, people are asking, if you're thinking of a non-cholestatic jaundice here, should you then be talking about BRIC and PFIC? No, that was a hypothetical thing which Dr. Setu Babu had said. We are not thinking of that, right? Fine enough. Again, I think people are asking about how common are the chronic hepatitis B flares with clinical jaundice and recurrence. I think that's a very valid point which we have discussed. I think that point is very well taken. Right, okay. So let's go on to the examination, I think, maybe. Yeah.
Yes.
Yeah, we can go to the, yeah, Dr. Govind, please. Yeah.
Can you just discuss with them that if recurrent jaundice is there, then what are the 4 questions or 5 questions you keep in mind, and then based on that you make your differential, like conjugated, unconjugated,
Sure.
or intra, extra, whatever the clinical pointers.
Yeah, absolutely. I think though we would be discussing all this approach maybe at the end also, but it's very good to, the first differentiation always would be whenever somebody comes with recurrent jaundice, or for that matter, even first episode of jaundice would be to be very, very sure whether you are dealing with a conjugated hyperbilinemia based on your assessment or unconjugated. We know that the bilirubinuria or the bilirubin gets excreted in the urine only when it is conjugated. And we also know that the conjugated bilirubin will occur only in patients with liver disease or biliary disease. So whenever somebody has conjugated hyperbilirubinemia or bilirubinuria or a high colored urine, that puts you that either you are dealing with an intrahepatic disease or an extrahepatic disease. And it rules out, or it excludes or keeps your possibility lower down towards, prehepatic causes, like we said, for example, hemolysis. Gilbert is also a prehepatic cause where there's a, problem. So I think that would be, they would become, little lesser. So I think with that, once you are sure this is hepatic or extrahepatic, then you have to, the second question you have to ask is it a cholestatic jaundice or a non-cholestatic jaundice? So once you are, if it is a cholestatic jaundice, then there are points of differentiation between intrahepatic cholestasis and extrahepatic. But if it is non-cholestatic, then I think you are focusing more on the liver, like in this patient. I think we are focusing more in the liver because it's a conjugated and it is non-cholestatic. So this is how I think we should be approaching. And Dr. Setu Babu, your comments on this?
I think we'll go ahead.
We'll go ahead. Okay, fine. So examination, please.
ठीक है, ये तो clear नहीं
General
कर
physical examination, patient's conscious, cooperative, and oriented to time, place, and person. She had a BMI of 21.3 kilogram per meter square with blood pressures of 110 by 64 millimeter of mercury and pulse rate of 78 per minute. In the general physical examination, pallor was and icterus was present, JVP was not raised, edema, clubbing, cyanosis, lymphadenopathy were all absent, thyroid was not palpable, and orodental hygiene was satisfactory. Coming to systemic examination, abdomen examination, this abdomen was scaphoid in shape, symmetrical. There were no dilated veins, visible lumps or peristalsis. Umbilicus was inverted. The liver was palpable 2 centimeters below the right costal margin in the mid-clavicular line, which was firm in consistency, non-tender, with regular margins, smooth surface, with no bruit. And liver span was 13 centimeters. Spleen was not palpable and there was no free fluid. In the CVS examination, respiratory examination, and CNS examination, all was normal.
So I think again, let me take out some questions from the chat box here. People are asking about the KF ring. Did you mention that? Was it negative or was it seen or what?
No, sir.
Cataract, signs of vitamin deficiencies, skin ulcers. How was the faces like thal faces, what we call, or thalassemia or something?
Sir, no features of chronic vitamin deficiencies. KF rings were not seen. And,
right.
I have a complaint against Akash that he did not positively mention KF ring not seen.
Sure,
that upsets a very chronic examiner like me.
Right.
Be careful, because that's actually the hero point of the case. All the time we have been discussed. And then I would put 3 questions with permission of Ajay. How do you look for KF? How do you look for KF ring? What do you mean by presence of KF ring? What are the conditions where you can get false positive KF ring? And does negative ring excludes Wilson's disease?
So to answer your question, KF rings are usually seen in the upper eyelid, and it is because of the copper deposition in the Descemet's membrane. And we can the confirmatory evidence would come from the slit lamp examination.
Not eyelid, the upper part of the cornea.
Upper part of the superior
limbus.
Yes, limbus. And so 40% of the patients of Wilson's will present with KF rings, and the presence, the absence of KF rings would not exclude Wilson's disease. And the other
is seen in. It is also seen in.
Sir, yes, the other clinical scenarios where KF rings would be present are, sir, other cholestatic liver diseases like sir, PSC, or maybe chronic liver disease patients can also have KF rings. Sir.
Good.
Okay, so I think again, Akash, before you can, maybe after examination, we can ask you that what are your possibilities now? Are these same, different, or you want to add or subtract anything out of the possibilities which you said earlier?
Sir, after the examination, I would still keep the same possibilities as I've kept before. The first one would be autoimmune hepatitis, second would be chronic hep B, and third, lower down, sir, I am still keeping Wilson's at the third possibility, sir. Because
you have not really got anything positive except for mild icterus and maybe just palpable liver. People are still asking you about, the scratch marks. No scratch marks, right?
Sir, there was no history of any
itching. There was no history of itching, right? Okay, fine. Right. So again, 2 questions people are asking: is a possibility of Dubin-Johnson syndrome? Will you like to consider?
Sir, Dubin-Johnson will present with conjugated hyperbilirubinemia, but sir, recurrent jaundice every year.
So do Dubin-Johnson comes with recurrent jaundice or persistent jaundice? That is the question.
Sir, persistent jaundice.
Usually they will have a persistent jaundice, right? I think so. They will not be.
But I think if people are asking, that is not totally wrong, because in Dubin-Johnson also we can have recurrent jaundice. We can have recurrent jaundice in Dubin-Johnson along with conjugated hyperbilirubinemia.
Right.
So that possibility should be kept.
Right.
We can. The most common is that most of these patients will have some jaundice, but there is a possibility that there may be recurrent jaundice in Dubin-Johnson also.
The other question which people are asking about, how about hepatitis A infection happening, again and again in this?
Sir, recurrent episodes of hepatitis A happening in the same patient and without any clustering in the family or in the locality, sir, it's a little odd. And there was no prodromal symptoms, although they can be absent in a few patients. But since every year the same illness happening in the same patient without any clustering or similar episodes in the family, sir, I have not kept hepatitis A as the possibilities.
Okay, and the other question, which is again in the chat box, is about, when you were talking about you're keeping AIH as your first possibility, and you said there was no autoimmune disease, but did you specifically look for vitiligo? Again, there's a question in the chat box.
Yes, sir, I've examined the skin.
But you did not mention that. I think that should have been mentioned, right?
Right.
Okay. And last question is about the DILI. Was there a history of CAM, and could it be, drug-induced liver injury?
So there was no history of CAM.
Any drug could you be implicating here? Because I think that's the question.
So recurrent episodes every year, there could be a possibility of drug-induced liver injury, but specifically in the history, there was no history of CAM intake. So I have not kept Delhi as the possibility.
Okay, again, I think comments are about to look for the thyroid in particular, alopecia in particular, about the autoimmune. Okay, so Dr. Setu Babu, Dr. Saraya, any questions? Yeah.
Yeah, I think we should ask what is the next now.
Okay, next would be then maybe we can involve Amandeep now. Aman, can we ask you how do you investigate this patient? We can go to the investigations with these possibilities which Akash have, and then Dr. Sunil can continue to show you the investigations. What do you want? How will you investigate this patient? Can we go back to the one slide picture? Yeah.
Sir, based on the history and examination, we have enumerated some possibilities right now. So the first possibility is autoimmune hepatitis. So I will go for some routine investigation and some specific investigation for the diagnosis. So first, I would like to see the routine investigation of this patient, like CBC, LFT, RFT, peripheral blood film, RFT, electrolytes, and coagulograph to see the status.
Okay. So we can show you those investigations, and maybe you can analyze those investigations or interpret or give us your inference from that. So this is what you can see. Can you look at the investigations? So
Yes,
we do have LFTs and CBC in 11 and 13 also, though the rest of the workup was not done that time as told by Akash. So can you look at all these and tell us your inference?
Okay, sir. What I see, patients' complete blood count report from 2011 onwards till 2014. What I see is that patient's HP is 11.7, 12, 11.4, 12.2. So hemoglobin of the patient has been fairly preserved, and also platelet is 160, 230, 212, and 225. So it means that there is no anemia as such, and then platelets also normal, suggesting that there is no really significant fibrosis. Coming to liver function tests, I see that in 2011 her total bilirubin is 6.6 with conjugated 3.6, and which is also seen in December 2013 and October, all these reports showing conjugated bilirubinemia. And enzymes, AST-LT in 2011 and 2013, probably at that time she had this flare of hepatitis. The enzymes are more than 20 times. And we have a alkaline phosphatase report of 139 and 132. So alkaline phosphatase is not very high in these two reports. And however, in 2014, as his AST, LT are slightly normalizing, alkaline phosphatase is slightly on the higher side. And coming to synthetic function, the patient albumin is 3.5, 4.8, and again 3.8 with INR of 1.5, 0.9, 0.8. So she had an acute severe autoimmune hepatitis in 2011, but her synthetic function largely have been preserved actually. And
Aman, I think we could see that, and you have enumerated them well. But the question to you is, Akash had kept three possibilities: AIH, chronic Hep B, Wilson's. Now, looking at these LFTs, can you infer or interpret this that, the enzymes are 20 times, at least we can see, 3 reports, and it's predominantly conjugated hyperbilirubinemia. Near normal ALK phos in 2, but then we have one report which the ALK phos is elevated. So how do you interpret? And ALT is more than AST. That's another thing.
Yes, sir. I can see that in 2011 to 2013, she had very high enzymes, more than 20 times with conjugated bilirubinemia. And keeping in mind the history of this patient, so I think these reports are consistent with autoimmune hepatitis. And because again, in Wilson disease, we don't really tend to see so much high level of enzymes going to the tune of 20 range and then resolving spontaneously by themselves. And also that in chronic hepatitis B, it's more of an anecdotal type of presentation. So I think based on these investigations, the possibility of autoimmune hepatitis remains the first.
Okay. Before I think Dr. Setu Babu asks you some question, 2 questions are from the chat box. Do we know the peripheral smear, and how about the gamma GT?
Okay, Aman, I thought you would also be adding, this is only to add, reticount is missing in this. That's what we were discussing, because even if you are autoimmune, the reticount would make some, instead of saying everything normal. The second thing is, given December 2011 alone, I don't think we can make a diagnosis of autoimmune on first. You could have probably said, given that particular first value, it still could be an acute hepatitis of any origin. You should be very, I want to know more from you rather than just getting biased by the history alone. It could be an acute episode. The second episode may be autoimmune.
Yes,
it's quite possible.
All these, the first differential is acute hepatic illness.
That's right.
And
no, you concluded it is, I have an objection. You suddenly concluded autoimmune with a bias. Go slow. I want to know more from you. Given first segment of report alone or first part of it, it still looks like a kind of an acute severe hepatitis. Look at the INR gone up a little bit. She could have actually slipped into an acute liver failure if she were not probably handled properly or anything. You agree with that, Ajay sir?
Yeah, absolutely. So I agree. I think so. These LFTs just tell you that this is an acute hepatitis. All 3, I mean, even 11, 13, it is not pointing towards any etiology. It could be all virus.
Yes.
I mean, and as we discuss, yeah, Dr. Raya, please. Yeah.
And another thing, like globulin is not very high. So that
globulin is not high. Yes. Yeah.
At this stage, we can at best say that patient's having hepatitis.
Hepatitis. Yeah, absolutely. Absolutely. And what is happening in October 14 and December 14? Looks like she was improving here, right?
Yes.
Yes, sir.
Okay.
She's likely toward 14, her bilirubin enzymes are settling, and then in December 2014, I think that's the time she presented was the bilirubin was settling and enzymes also.
So again, people are asking about globulins, retic count, LDH, ESR, gamma GT, and slit lamp. I think very important, feedbacks we are getting from the audience. Thanks, audience, for that. I think so. How about your, LDH, retic count, globulin, slit lamp?
Yes, I think since we have an acute hepatic illness at this point of time, so I would like to see the evidence of hemolysis and then slit lamp examination.
Oh, but are you seriously considering hemolysis here? That is what we are asking. Conjugated hyperbilirubinemia, enzymes in thousands, and ALT more than AST. Are you considering hemolysis? Yes or no?
No, sir. As I already said, that such a high level of enzymes are more suggestive of acute hepatic illness, and hemolysis is less likely possible.
Yes.
Agree. Here, so enzymes wouldn't be so high. So
agreed. Okay, fine. So what else do you want now? What further?
Sir, since acute hepatic illness is differential here, so I would like to see her viral markers.
Okay, we'll show you the viral markers. So all viral markers A to E were negative. What else do you want now?
Okay, sir. If all the viral markers are negative, so I think the next I would like to have autoimmune markers in this.
Autoimmune markers. So all autoimmune markers, again, ANA, asthma, anti-IKM1, AMA, and PCA, which we do as a panel in PGI, they were all negative. So what do you want now? So again, I think let's go, before we go further, I mean, is it again helping you whether this was a acute viral hepatitis which was happening, and obviously this episode was also there, versus autoimmune, or it could still be, both the possibilities could still be open? Could it be, yeah, okay, you can respond and then we can ask you some questions. Could it be?
Yes, sir. I think still possibility remains open: seronegative viral hepatitis versus autoimmune hepatitis.
So
Even
both
though,
seronegative possibilities are still open, right? Okay, fine, very well. Right. So what do you want now?
sir, the autoimmune markers, the conventional ANA, SMA, LKM are negative. Also AMA and PSA. So if we can get extended panel autoimmune markers.
What do you want in the extended panel, and what do you want to look for that extended panel? Yeah.
Sir, soluble liver antigen or liver cytosol 1, maybe P and K, and if they are available, then I would like to see them also.
So we had SLA and I think yeah, LC1 in this, they were also negative. So what do you want now? So in what percentage, the question would be that you have a seronegative hepatitis, routine conventional autoimmune markers are negative. So what percentage you will have these extended panel, any of the marker positive? How commonly does it really help you? And these may not be available all over. Yeah.
Sir, seronegative autoimmune hepatitis can be seen to the tune of 25%. And also in acute severe hepatitis, also 25% of patient can be seronegative. So even though these conventional and extended panel autoimmune markers are negative, so this does not really rule out the possibility of autoimmune hepatitis at this stage. So
okay, Dr. Setu Babu, your thoughts here?
I don't. You only need to know that there is a negative component in autoimmune hepatitis, and basing on that, probably you know that the next algorithm goes into a more definitive investigation. Let them tell. I don't want to.
Okay, fine. So, Dr. Saraya, any questions at this stage?
No, not.
Okay, we can go ahead. So, what do you want further, Raman?
Sir, going further, I will like to see if total immunoglobulins of this patient.
Okay, so you would like to look at the IgG. Okay, we'll show you the IgG was 18.5. Can you tell the audience what is the normal value and is it elevated? And if yes, what times you call it? In AIH, you always say 1.1, 1.2 times or whatever.
Sir, IgG total is high. The high cutoff range is 16 gram per deciliter. So it is more, and it is more than 1.1 times. So which means that it is significantly elevated. So I think the total IgG levels are high, and they kind of help me to.
Is it possible that somebody has elevated IgG, but this is not because of the autoimmune hepatitis or because of something else?
Yes, sir. In high fibrotic condition, even in cirrhosis, the total immunoglobulins can be high. So this is also a possibility. Also, other conditions with hypergammaglobulinemia, patient can have high total IgG levels.
Sure. Okay. So anything else okay, let me look at the chat box. IgG total, people have asked that, you have already answered. And people are asking, would you like to repeat the autoimmune markers here? Because, once negative not means that next time you may get it,
Yes, sir. It's a good idea to actually repeat autoimmune markers. But they can be sometimes be negative in initial report, and subsequently we might 10 to 5, 25 to 35% can have a positive serology report in the subsequent death. So that can be done. So
okay, Dr. Setu Babu, please. Yeah.
When you were asking serial ones, let's say it is positive before, can the titers come down with treatment or titers change with treatment? Because this is something which we need to also say that.
Yes, sir. Once we start the treatment, the biochemical remission, the total IgG levels, they can tend to become normalized, and so that can happen. And
honestly, Ajay would watch for me, and it is like, if it is negative, that coming positive is less likely. But if it is positive, the titers coming down or even becoming false negative or temporary negative because the titers are slow, your detectable test system all make it. So negativity does not mean negativity. Positive could be false positive in our all practice guidelines.
Yeah, the only other thing sometimes what we observed is the kind of methodology you use to test these
Correct.
autoimmune markers.
Correct.
Whether it is immunofluorescence or it is ELISA, that also does make difference in your positivity. And people are also asking about, I mean, does the dilution help you in determining, whether they are going to be positive or negative? I think dilution, my only perception would be dilution we would look into if you are getting a positive marker. But if it is negative, I think probably the dilution, I'm not sure. Dr. Setu Babu?
Yeah, actually, there is one more method called CLIA method, that is chemiluminescence.
Right,
These are all quite, as I said, negativity doesn't mean anything, but positivity, if it is positive in this circumstance, the severity doesn't matter to us. In fact, we take the threshold to start on therapy basing on that single positive result. That's what I feel is.
Okay. So what do you want, Aman, now after this?
Sir, I think I like to see ultrasound abdomen of this patient now.
Why do you want ultrasound?
Yeah, why do you want ultrasound? And people are asking about, again, KF ring and ceruloplasmin. Do you want that?
Even though, sir, we have a fairly feel that the possibility of Wilson's is very unlikely in this patient. But however, I think it's always a good idea to fully rule it out. So I would like to see KF rings and
Everything costs, to doing this thing. So if you had a possibility of Wilson, so, and as I said, as we discussed, somebody coming in thousands, the enzymes are in thousands, recurrent episode, even the clinical picture was not fitting into, Wilson. The LFTs were not fitting into that. There was no evidence of hemolysis. Yes, I think it was done in this, which was normal, but then, yeah, Dr. Setu Babu, yeah, please.
I want to give you one test to save the cost effectiveness for Wilson's. Which one you prefer? I'll give you one test. Don't mind cost. You have 5 panel tests, including say 24 hours or deep pencil challenge, whichever you want. Just tell me which one is that. I just want to know how much you know about this Wilson's, which test is sensitive, which test is specific. Sorry for the question, Ajay.
No, that's absolutely right. Yeah. So what do you want, Aman, for Wilson? One test if you are asked.
Or you grade the test. I don't mind. You first is second, third, fourth, fifth. Copper level, ceruloplasmin level, and then urinary copper level.
I think 24-hour urine copper level I would.
With or without challenge. There is one more added nuisance is challenge. Deep end challenge is there. I want you, I expect you to know all these things, whether that fits into the case or not. I want to know how much you know rather than you are prepared for this particular case. But I want to test you a wider approach. Like I said, you could have probably said, I wouldn't do Wilson's, but if I'm asked to do Wilson's, I would prefer out of the 5 available tests, this one I prefer. Like 24 hours urine copper is quite sensitive. But if you add deep end challenge, it is much more sensitive. I hope you agree with this, Ajay.
Yes.
Yeah, absolutely fine. But the only thing I was just thinking about is, can you have Wilson, or what clinical situation can you have Wilson with normal ceruloplasmin?
I agree. This is again another very important, which we know very well. It can happen. Yeah. Almost, I believe, if I'm right, 10 to 20% of the Wilsons do have almost normal ceruloplasmin, and they don't.
Yeah, and especially if it is going up because of the acute phase reactant. Yeah. Okay, so Aman, with this now, what do you want now further?
Sir, I would like to see the ultrasound of this patient.
Okay. So ultrasound was largely normal. It was a normal size liver, normal ecopectin, no IHBRD, spleen normal, and the portal venous system normal, GB normal. So what do you want now?
So ultrasound is normal, sir, and including portal vein and hepatic veins are also normal. And so I would like to see fibroscan of the patient. I would like to see how much.
Why do you want to fibroscan here? Why do you want?
Sir, patients having recurrent episodes of acute hepatitis and still having high enzymes 85 and 68. So I want to know how much is there any fibrosis present in the.
Okay, Dr. Setu Babu. Yeah.
I think fibroscan would come after a definitive diagnosis, because here, whether there is a fibrosis or not, it won't add to your diagnosis. Does it add to your diagnosis or eliminate a diagnosis? FibroScan is an interesting investigation. I know when you're talking your priority of non-invasive approach, you are talking as a helpful tool and it is readily available. But whether it FibroScan 8, 12 or 15 did not add to your diagnosis.
And the other question, which is again there on the chat box, is it the right time to do FibroScan? Because or are you likely to get a falsely elevated value here? What were the liver enzymes, last liver enzymes, 2014 when she came?
Bilirubin was 1.78 and AST/LT was 85 and 70 odd.
Okay, so I think so. When you are likely to get an falsely abnormal FibroScan based on the liver enzymes, if they are more than?
If they're more than 20 times acute hepatitis presentation, then
Definitely if they are more than 10 times and sometimes even more than 5 times, but less than 5 times should not make major difference here, right? So yes, I think we can look at this, but as rightly put by Dr. Setu Babu, this will not help you in making the diagnosis. This will help you making maybe the staging the severity of the disease, but not in making the diagnosis. So the LSM was 4.9 and the CAP was 222. Your thoughts on this or comments on this?
So sir, liver stiffness is 4.9, so I think that's normal. So I think after this we can have liver biopsy.
No, again, questions in the chat box are about anti-HBC total, anti-HBS, HCV RNA. Would you like to do these?
Sir, as we already discussed that the possibility of CHP flare is slightly less because of more of an anecdotal hepatitis kind of presentation is seen in hepatitis B, and no evidence of decomposition, no evidence of fibrosis in this patient. So I think the possibility of chronic hepatitis B flare is slightly less in this at this stage of this patient. So I can go for liver biopsy in this patient.
Okay, Dr. Setu Babu. And Dr. Saraya, please. Yeah.
You want a standard liver biopsy or guided liver biopsy?
I think, sir, we can go for a guided liver biopsy in this patient.
You exclude portal hypertension in this patient, is it?
Yes, sir, I think the
the fancy question is, would you like to do an endoscopy?
Sir, platelets of the patient are normal and LSM is also normal, so there is no real indication for screening pre-endoscopy in this patient.
Okay, say that.
I think we agree. And again, somebody had a question about that if you want to assess fibrosis and centers, especially those who don't have FibroScan, how about FIB4 in this clinical situation?
Yeah, that's a good question.
Yes, sir. FIB4 again a non-invasive marker for fibrosis. It can be done in this patient. However, I think the utility is not so high in presence of autoimmune hepatitis. So
most of the data on FIB4 is available in which liver disease?
Sir, chronic hepatitis C is
absolutely. So chronic hep C, or maybe with the NAFLD also fatty liver you have. Yeah. Okay, again the question is about the celiac serology here. Would you like to do a celiac serology? Would it be celiac disease presenting like this?
Sir, again, if we go back to the history of this patient, so there were no real history suggestive of diarrhea, indigestion, and growth. Anemia was not there, and there is no evidence of growth retardation. So there was no real symptoms. Even though ASLD mentions celiac serology as a workup in evaluation of autoimmune hepatitis, but the possibility and is very less in this patient. So I think we can avoid that investigation.
Aman and Akash, when you are in the examination mode, most of the examiners wants you to know how much you know. If you restrict to only this case, I'm not sure whether you know something more or not. For example, the behavior of adult celiac is much different from pediatric celiac. I think you probably need to look at those areas and learn more about that. Keep your notes ready and give us more inputs. You are only answering that particular question, not going slightly out of the thing. Then I'll enjoy, yeah, he knows more. You are only answering very restricted tubular answers. So
And
you can expand.
yeah, the two more things in the chat box. Somebody has written no signs of malabsorption, normal albumin, normal HB. Would you still go ahead with celiac serology? And the other question people are asking, how about doing an MRCP? Hmm.
Yes, sir. Even though there is no evidence of cholestasis in this patient, but going for a cross-sectional imaging before going for an invasive investigation is, I think, a good idea, and maybe we can consider that doing MRCP in this patient.
But is it a stronger indication or a relative indication?
It's a relative.
So mention that it's a relative indication, just because it's not a good idea actually. Because
okay, I think good idea. So the another question which I think before we go on to the next is, you have asked for liver biopsy. So what are your expectations for liver biopsy? Do you think that the biopsy is going to make a diagnosis here, and will it help you in the management in this particular patient?
Yes, sir. Liver biopsy is an important component of all the scoring system that have been designed for autoimmune hepatitis, can help us for the diagnosis of autoimmune hepatitis, and then also rule out other causes also. And then subsequently, if we establish the diagnosis, then we can also, monitor this patient and after treatment look for any histological remission. So typically in autoimmune hepatitis, we have a characteristic findings which can help us to establish the diagnosis of autoimmune hepatitis.
Okay, I think Dr. Govind want to say something. I think probably we are getting short of time, and Dr. Setu Babu, please.
Not in sort of time. I just wanted a couple of questions on celiac serology.
Yeah,
So
sure.
celiac and liver is still evolving, and we do not know everything about celiac and liver involvement. But there are patients where there's a predominant liver involvement without any evidence of clinical malabsorption, even with normal hemoglobin. So therefore, doing celiac at this stage, once we're discussing a young child, a young person with recurrent jaundice, is worth doing. It at best it may be negative, but if it's positive, then you get the prize of treating a patient and curing the patient to a large extent, right?
Absolutely.
So doing this test may not be a bad idea.
Yeah. Okay, so Dr. Setu Babu?
Yeah, I think you should go ahead.
Okay. So I think probably we didn't have the celiac serology done in this patient, and I think the MR was also not done. So we went ahead and did a liver biopsy in this patient. So maybe we can show you the liver biopsy findings. Yeah.
Aman, can you stop it for a minute? We'll take the poll question.
Poll question. Okay. Good stuff. Okay. So the audience is at poll time now. Okay. So I can read the question for you. Which of the following is the most characteristic finding in AIH? And peripolysis, interface hepatitis, hepatic rosetting, and central perivenulitis. So, is the poll evident to the audience?
Yes,
No, this will not be seen to audience. This will see only to us.
Oh.
We can read out. Okay, the code.
No, I can't see the results also, which was coming earlier.
Yogita?
Yogita, we can't see the results which were coming earlier on the screen.
Sunil, can you see that?
Yes, the answers were done by 77% of the people.
Right.
And interface hepatitis was answered by 56%. Empiripolysis was answered by 32%. Rosetting by 10%. And central perivenulitis by 3%. But the point very interesting is 77% of the people answered, and the 56% goes to the most important character, interface hepatitis. Aman, can you describe what is this interface hepatitis? You're not good pathologists, but some of the areas we know here and there definitions.
Sir, interface hepatitis refers to a condition in which there is a portal inflammation, and this portal inflammation tends to spill over into that the interface between the hepatocytes and the portal tract. So, so this is associated destruction of the hepatocyte. So that is we call interface hepatitis.
There is also one more thing, that means we are leading towards fibrosis.
Yes, sir.
I think before we go on to the biopsy finding, I think very important question which we probably did not discuss while we were discussing the liver functions and people spoke about MRCP. Aman, can you tell me, she also had, the last two LFTs had shown that she also had elevated alkaline phosphatase. So if you were thinking of AIH, were you also considering a possibility of overlap? If yes, overlap with what? PSC or PBC?
Sir, alkaline phosphatase at this young age of 17 years. So overlap syndrome will likely be PSC in this patient. That is known as autoimmune sclerosis.
You think that alkaline phosphatase was important, and if that was the case, and if you think PSC was a consideration, I think then the MRCP becomes all the more important, right?
Yes,
But then is it possible that her alkaline phosphatase was not because of liver disease and it was just because of her growing age?
yes.
Yes.
About up to 3 times alkaline phosphatase upper limit of normal can be seen in patients.
Yeah, so I think it could be related to that, but yes, I think the points are very well taken. We must look at overlap in a setting where you have both ALT and the alkaline phosphatase elevated, and MRCP should be done before you go ahead with the liver biopsy. I think points are very well taken. I think should be done. Okay. Yes, Dr. Setu.
Is there anything that really points out your diagnosis in the 4 histological qualities that we mentioned? Anyone which goes close to your diagnosis? You're close to autoimmune and.
Sir, presence of interface hepatitis with lymphoplasmacytic infiltration is kind of more typically related to autoimmune hepatitis. However, no single entity of histological manifestation can establish a diagnosis of autoimmune hepatitis completely. So,
yeah,
I think
so.
Okay.
All 4 can be seen.
Yeah, all can be seen. And Aman, again, the question important would be, what is interface hepatitis was previously called as piecemeal necrosis. This is just the spillage of inflammatory cells beyond what we call the limiting plate, right? So there's a limiting plate at the portal tract. So this is, I personally feel this can be seen in any chronic hepatitis. It could be seen even in chronic hepatitis. So what is so characteristic about this interface hepatitis would be the type of infiltrate. One is that it has to be a dense infiltrate, and second, it has to be lymphoplasmacytic infiltrate, right? So I think interface hepatitis per se would not be characteristic. And this is my personal, maybe Dr. Sunil can also chip in here, and Dr. Setu Babu or Dr. Saraya.
So I completely agree that it's the inflammatory infiltrate which is more important.
Right,
And
right.
if there is presence of enteroporosis, I think that is also a characteristic.
Right. Okay. Dr. Saraya, Dr. Setu Babu.
Yes, I fully agree with Sunil. And I think there are a few more tests which should be done before starting therapy.
Yeah, sure.
Because once you are considering a possibility of autoimmune hepatitis, I think, and you want to put this patient on therapy, certain investigations which are needed, you have to rule out occult viral infection. Number 2, HIV infection, and osteoporosis or osteomalacia.
Absolutely.
These things one should always keep in mind and one should investigate before starting therapy.
Absolutely.
If she were to be seropositive, this histology could have confirmed that she is AIH. The problem comes with seronegativity. You should be doubly sure that you are not missing anything else. Just a caution.
Yeah, sure. Okay, so can we show the biopsy findings here? Yeah. So Aman, can you just read this biopsy slides?
Yes, sir. I can see a portal tract at this.
Mandi, can you put your cursor if you
Can
can?
you put your cursor and show us the,
So this is actually.
Okay, the control is not with you. Okay, maybe Dr. Sunil can do that.
Yeah.
So this is where it's a limiting plate, and we can see the spillage of inflammatory cells into the hepatocytes. So suggesting interface hepatitis, and also this portal tract, which sir is showing, also having mild to moderate inflammatory cells in this portal tract. So
Can we go further? Next slide, please. Yeah. What is this showing?
Yeah, sir. This is again clear diagram which showing this spillage of inflammatory cells into the hepatocyte. So interface hepatitis in both these portal tracts suggestive of interface hepatitis.
Can we go further? So can you identify the type of cells and tell the audience how do you identify these cells?
Plasma cell.
That's a lymphoplasmacytic infiltration. So the cells with the eccentric placed nuclei, this particular cell. So this is a plasma cell, and the cells with the centrally located nuclei are lymphocytic cells. So it's more of a lymphoplasmacytic infiltration, and along with interface hepatitis. So quite sensitive for the possibility that we have kept. So yeah.
So what is this stain and what is this being shown here?
So sir, this is Mason trichome skin film, and we see there is a portal fibrosis is also there. So again, it's only involving portal tract. So it's a mild fibrosis is there, sir.
Okay. So based on this, again, what would be your, final diagnosis? Both of you, I think, can maybe tell us your final diagnosis, and then we discuss maybe 5 minutes on the treatment here.
Yes, sir. Keeping in mind the age of the patient, the history of the patient, and the investigations that we have done in presence of high IgG and negative viral markers and a biopsy which is suggestive of autoimmune features. So I think we can make a diagnosis of syndromic diagnosis of recurrent hepatitis, probably autoimmune hepatitis in this patient.
So the questions again in the chat box are two very important questions. How do you know this was a liver tissue? Number one. And secondly, can you tell, I mean, 2/3 only AIH plasmacytosis would be seen only in 2/3, and the plasma cell infiltrate can be seen in other causes of chronic hepatitis also. So what is so peculiar about autoimmune hepatitis here?
Sir, the presence of this portal infiltrate with lymphoplasmacytic infiltration and interface hepatitis, sir, this is quite characteristic of autoimmune hepatitis. Not other conditions are associated with lymphoplasmacytic infiltrates in presence of portal tract and this interface hepatitis.
Dr. Setu Babu, Dr.
Do you need a hepatitis B staining for this? We were used to taught. Ajay is actually very junior to me, but the word Shikata staining is supposed to be said. We had, at least in my exam, the question, how do you stain hepatitis B? How does it look? The red spots, beautiful spots on Shikata stain, the RC staining. I think you need to know a bit of it, not really in the modern exam. But when you talk about histology, you need to have what are all the possible stains to identify. And here also, I'll just give a tip that suppose there is an amyloidosis of the liver, what stain you are going to use. Just keep an idea, keep a note on this. Just don't restrict yourself to this case. What stains will give what finding, and what histology would give what finding, low level, high level, ultra high level, what will be the finding.
I think two, three more questions, which are again very important. One is about the hepatitis B staining, copper staining, right? And lastly, again, the people are asking, would you now like to do the revised, AIH, international AIH scoring or a simplified scoring? Now you have a biopsy with also to give her a final, or this is good enough? I mean, is scoring really important, or you can just make a diagnosis?
Sir, in presence of this seronegative hepatitis, I think the revised scoring system is better for making the diagnosis of autoimmune hepatitis. So I think we will stick to revised scoring system in this patient.
Okay, maybe I'll request Dr. Sunil to tell us maybe a little bit of scoring here. Do we have a poll question?
So we have a poll question before.
Okay, we have a poll question. Okay, poll question for the audience, right? Okay. So which of the following is not included in the simplified AIH scoring criteria? IgG more than 1.5 times, absent viral markers, characteristic biopsy findings, and ANA more than 1:40. somehow the poll is not appearing on my screen, but maybe somebody else can. Dr. Setu Babu, if you can read the answers.
Actually, the response rate is close to 100% people who answered. Serum IgG more than 1.5 times is answered by 50%. Absent viral markers 10%. Characteristic biopsy findings 16%, and ANA 1:40, 24%. I think the sensitive point everybody was mentioning is about IgG more than 1.5 times. Here we have a funny thing, it is totally not 1.5. We have very, very difficult situation there. And Aman seems to have, caught by the IgG levels, which was marked.
Yeah. Okay. So can we go further? Sunil, can you tell us the criteria here and yeah, the simplified
So
criteria?
this is the simplified scoring system, which was published in hepatology in 2008. And I think this is the score which is being used more commonly by all the physicians now and applicable more in a seropositive state.
Can you put the video on?
So it is being used in places where the autoimmune markers are positive. And if you take antibodies, IgG levels, liver histology, and the absence of viral hepatitis. A score of more than 7 is definite AIH, and a score of more than 6 is considered as probable AIH.
So what would be the score in our patient? Can we just score it?
So 2 plus 2, 4.
It will be probable.
It will be 6.
It's
Probable.
Yeah, 6, sir.
6, okay, because we had absent autoimmune markers. Yeah,
Yes,
yeah. Okay.
absolutely.
Okay.
And since we know that the final diagnosis is seronegative autoimmune hepatitis, as Aman has already said that the revised score is more applicable here. And in this obviously is a cumbersome score, and at times you will not have the HLA and you will not have other markers. Sometimes the history of drugs and alcohol might not be there, but this is a good score. And if you can calculate the complete score, probable is if the score is between 10 to 15, and definitive diagnosis if it is more than 15. And this has a pre-treatment score as well as a post-treatment score. Important is, again, if you look at the histological features, this has really importance in this. The histology is important for this score as well.
So what would be the revised score in this girl?
So whatever parameters we had, the score was coming out to be 14, and it is kind of.
So it is still the probable. Okay. Finally. So I think, it is probable. Aman, so would you like to treat her as AIH, or how would you like to treat her, or what will you do now? I think let's go on to the final leg of our discussion in this. Yeah.
So can we take the poll question, sir, before?
Okay, we'll take a poll question.
Yes.
Yeah, sure. So all of the following are the first line drugs for AIH except prednisolone, azathioprine, prednisolone plus azathioprine, and tacrolimus. Okay, go ahead.
Tacrolimus got almost 93, 94%.
All right.
I think everybody agrees with TAC as the drug.
Yeah, it's not the first line. That's fine. Okay, that's I think. Okay, so Aman, how will you like to treat her?
So I think after going through this investigation and history examination of this patient, so I think we can start this patient on immunosuppressive therapy at this stage. As Seth has told that before we actually switch to this immunosuppressive therapy, we'd like to rule out any anti-HBC and then DEXA and all metabolic markers. And then once we have started the treatment, we'll start her on prednisolone and dose of 0.5 to 1 milligram per kg dose. And then we can add, after 1 to 2 weeks later, we can add azathioprine in this patient. And this helps us to, kind of evaluate the patient, whether it's responsive or not. We can get TPMT activity of this patient, and then we can also avoid azathioprine-induced hepatitis in this patient. So we'll then switch azathioprine and prednisolone, and then we'll look for treat this patient on this regime, and then slowly taper off this medication at 5 milligram per kg every 2 to 3 weeks till we try to maintain the biochemical remission of this patient, and then gradually withdraw steroids in this patient, and then we can actually maybe switch to steroid-free treatment. Also.
Fine. I think, Aman, because the idea of doing this case discussion was to mainly tell you about the approach towards a recurrent jaundice rather than discussing the AIH in totality. So maybe I think let's not get into the more details here. And again, maybe take one or two questions here. And if Dr. Govind permits, I think we can go on to the second case, because the two questions in the chat box are about that TPMT, should you really be doing it? It is really advocated before putting somebody on azathioprine, number one. And the second question people are asking about the budesonide versus prednisolone in a non-cirrhotic setting. So she's a non-cirrhotic, right? So budesonide versus this thing. And then maybe can I ask Dr. Govind, can we go ahead with the second case or continue with this? We can even continue in this, or we can have another case.
We can have another case.
Oh, sure. So some comments from the Dr. Setu Babu and Dr. Saraya, and then Aman, your response to these two questions from the chat box.
I will not question, but I will only leave some questions for reading. That is, what happens if you get a flare while on therapy? Second thing is, what is the role of a follow-up biopsy? This case is clinically not very active case, and you may get some steroid-induced well-being, but then you need to have certain guidelines about flare and follow-up biopsy. You will read that, don't answer.
Okay, fine. Yeah. So Dr. Saraya, any quick
comment? In fact, we can go for next case.
Next case. And the only thing I would like to tell about this patient was that we were, again, this was a probable diagnosis. She was put on treatment. She was from a remote area of Himachal, and after 2 years, she kind of defaulted. So she left treatment and she came back to us with flare. So now if you apply the revised criteria, which is actually post-treatment also, she came with a relapse. So that, was kind of, confirmatory with us. And we again started her immunosuppression and she again responded. So I thought it was, even though it was fitting into a probable, but that kind of default and her relapse and then again response, helped us in kind of making it a definite diagnosis. So any thoughts on that? Otherwise, we can move on to the next.
That's a good clinical event follow-up.
Yeah.
Ajay,
We didn't want her to be defaulted, but then she defaulted and, that helped.
Actually, this will happen. Only thing is very quick, your comment on flare-up while on therapy is another big subject by itself.
Yeah. Okay. So, Dr. Wayne, we can go to the next case.
Yes.
Dr. Sunil, do we have any poll here? No.
No, sir. So just to show you these guidelines, and AZA and prednisolone remains the standard of care. And in ASLD now, they have included budesonide as first-line therapy also. So I'm not going into details of the treatment. Steroid, AZA, and budesonide are the treatment modalities which can be used.
Right. So I think that was a question about budesonide. Okay, let's go on to the second case then.
Ajay,
And maybe Dr. Govind, please.
I have a question. Just not a question, but an observation that this young girl, 9 years of disease, 2011, 2021. So would she have gone to cirrhosis by now?
No, she's on our follow-up. Rather, I saw her only a month back and she's still doing well. We did her fibroscan done and it's a non-cirrhotic liver still. So autoimmune really do well, I think, given,
I think this is a place where fibroscan might be more useful.
Yes, we did that fibroscan now, and that's still a non-cirrhotic. Okay, so let's go on to the second case. Aman, can you present the second case now? And be very short on this. We maybe just have 20 minutes to discuss the second case. So you can just be very precise and short.
Okay, sir, this is our patient, 20 years old male, resident of Pune, Himachal Pradesh, and he's a student. So again, his chief complaints were recurrent jaundice since 1 year. So coming to background history, the first episode was in September 2019 when patient has jaundice with high colored urine and was associated with itching, which was progressive, more in palms than soles, and it used to interfere with sleep, associated with clay colored stools and fatigue. Patient was admitted for 21 days at a local hospital and he improved symptomatically. The second episode happened in October 2020 and it was a similar illness of cholestatic jaundice associated with clay colored stools and pruritus. Now patient came to us with cholestatic jaundice since 3 months when there was no history of any pain, abdominal fever, vomiting, abdominal distension, hematemesis, melena, bleeding manifestation, or drop in sensorium. In past history, there is no history of any diabetes, ischemic heart disease, tuberculosis, bronchial asthma, thyroid disorder, or any surgical intervention, and no history of any blood transfusion. Patient consumes mixed diet, and there was loss of appetite by 50% and loss of weight of 2 kg in 1 month. Non-smoker, non-alcoholic, no addiction, no high-risk sexual behavior, and no tattooing. satisfactory social and academic performance in school. And family history, there was no family history of jaundice or pruritus, no history of consanguinity. Patient had one sibling, and both his sibling and parents are healthy.
So we can take the poll question here. Sir.
Okay, I think let's go ahead with the poll. Which of the following is a likely cause of jaundice in this patient? PSC, overlap, Wilson's, or brick? Setu Babu, if you can,
it's not settling, it's moving fast. Because we need at least 80% of the people to, I think that now the PSC is 14%, overlap syndrome 9%, Wilson's 50%, brick 27%. Probably statistically Wilson's comes up. Maybe people are all attracted by Wilson's and.
Okay, so Aman, how do you analyze this story or this history of again a young boy who's come to you? This time there are definite cholestatic symptoms, and he had one episode of cholestasis earlier. And did he kind of normalize in between, you said?
Yes, sir. There's a history of documented normalization of
normalize, and then he had the second episode when he has come to us, and the second episode is going on, right? So, what is your analysis?
Sir, again, a young male with cholestatic jaundice.
I think before you answer, I think I was just you go back. The question is, why are people choosing Wilson's with a cholestatic presentation? I think that message should be very clear that the Wilsonian will not come with cholestasis. So this is my thinking.
Least likely cause, sir. Least likely cause.
Least likely. I think Wilson would be the least likely. Usually they can even have normal alkaline phosphatase. What to talk of a clinical cholestasis? They will not come as clinical cholestasis. So I don't know. I was a little surprised, 50% of the audience choosing Wilson as the possibility where somebody is coming with recurrent cholestasis. So that should not be. Yeah.
That's why I was mentioning people are attracted by Wilson.
Wilson, okay. Okay, Aman, go ahead. How do you analyze? Yeah.
Yes, sir. On the basis of history, our possibility is the recurrent intrahepatic cholestasis. The first possibility we have kept is primary sclerosing cholangitis with or without overlap. The second is the viral hepatitis. Third is benign recurrent intrahepatic cholestasis. And maybe the least likely possibility of progressive familial intrahepatic cholestasis.
So can you quickly tell us the points in favor and against each possibility? Quickly, yeah.
Sir, again, quickly, I would like to say that patient young male and having a cholestatic jaundice. So the possibility of primary sclerosing cholangitis becomes the first possibility. However, there is a less likely of resolution of this high jaundice, which spontaneously resolves. So this is a slightly odd point against this thing. So coming to the viral hepatitis, again, recurrent episodes can happen with.
Can't you have a PSC patient presenting with jaundice and then resolving and then coming with another episode? Is spontaneous resolution a definite point against?
So relative points are.
Can happen.
It can happen, yeah. Dr. Setu Babu?
Yes, it can happen.
Yeah,
it will be a rarer presentation. We expect a progressive disease with bilirubin not disappearing actually.
Yes, yes. Okay. And viral hepatitis?
Viral hepatitis, again, there is a possibility of viral hepatitis. As such, a patient can present with viral hepatitis. However, the odd point again, this patient was that patient had cholestasis at the onset of.
So when do you have cholestasis in acute viral hepatitis? If you're saying it was the odd point at the onset.
Usually, sir, it usually follows the onset of jaundice about 2 to 3 weeks, and then patient usually have pruritus in late phase.
There's something known as prolonged cholestasis in acute viral hepatitis, when the disease is getting prolonged and then enzymes are also settling down and everything, and patient starts having cholestatic symptoms. That happens maybe later in the course of the disease rather than to begin with. Okay. Third possibility.
Sir, again, young patient, cholestatic jaundice, and there is a documented complete resolution of his cholestatic symptoms. And the odd point was it's a relatively less common disease. So this is a relative point. So still we would like to rule out these three possibilities after.
No, the people are asking about, again, viral hepatitis A, which can have cholestasis. So could it be just two distinct episodes of viral hepatitis A?
Yes, sir. That's why we have kept the possibility of viral
Okay,
hepatitis.
okay. You had kept that possibility. Fine. Dr. Setu Babu, please.
Could it be E going into chronicity?
Oh, yeah. Chronic HEV. So that's the question.
Yes.
Yes.
The first episode is
Chronic.
typically E. And second thing is, I'm little disturbed. You said always overlap syndrome. Could you be more specific? Which overlap is overlapping the syndrome?
Sir, PSC, AIH overlap syndrome.
Yeah, you please say which one is, PSC, PBC, PSC, AIH, AIH,
PSC,
PBC. All these
PSC.
combinations are of a histopathological, serological, presentations, false positivity. You should be very careful again in this area. When you mention one entity, what is the nearest serology, nearest histology? When it comes to overlap, everything overlaps, and then your approach to treatment would not make much an approach to the diagnosis. I think there you need to be careful. Majority of them have steroid as still their drug. For example, you might say MRCP, which I know it will be discussed. Sorry.
Okay. So what did you say about the break?
Yes, sir. I said that the patient, young male in second indicator of life, having cholestatic jaundice with complete resolution of symptoms, and again coming to us with the same cholestatic jaundice with intense.
So what is odd for break here? Anything odd for break?
Sir, I only felt that it's a relatively rare entity, and so even though there is nothing, no solid point to rule it out completely, so I have kept it third possibility just on the basis of statistics and relative.
Okay, Dr. Setu Babu. Yeah.
Would this be a Dubin-Johnson syndrome? You didn't think of it.
Yeah, you didn't think of it. So can Dubin-Johnson syndrome, I mean, they have, can they come with cholestasis number one? First question. And the second is, can they have normalization of bilirubin in between? This is the two question.
But the question is good one.
Can you have cholestasis in Dubin-Johnson? First question.
Yes, sir. Cholestasis can be seen, but there is as we discussed earlier, also the normalization of bilirubin to complete normalization of LFT and bilirubin is not really seen in Dubin-Johnson syndrome. So in this patient, there was a complete resolution and there was no real precipitating thing, and patient having severe intense pruritus. So slightly odd against.
Okay, I think we can.
My last question,
yeah.
just to trouble you, could this be a G6PD deficiency? Cholestasis being there, of course.
Sir,
I just want to extend your knowledge, not really. You need to know these questions can, come in differential diagnosis, can be excluded very fast, but not to think of them, not to know of them is not expected. So G6PD again is a very important entity for us. Hemolysis being a dominant.
See, the Dubin-Johnson can obviously always comes with conjugated hypervolemia, but they usually do not have cholestatic features. That is number one. Now, the fluctuations are well known in Dubin-Johnson. They may not touch normal, but fluctuations are well known, number one. This other question in the chat box is about PFIC3, which you thought initially. Could it be PFIC3? So for the sake of audience, PFIC3 is the progressive familial intrahepatic cholestasis type 3. We have PFIC 1 and 2 versus PFIC 3. Aman, can you tell us, could it be PFIC 3? Which occurs in adults, whereas type 1 and 2, which we said occur in children.
Sir, PFIC 3, we had thought of the possibility of PFIC 3. However, PFIC 3 is again a progressive disease, and once there is a cholestasis, so resolution of cholestasis is unlikely, and also is associated with other associated features like growth retardation, mental abnormality, and extrahepatic features also. So
okay, yeah, sure. I think, and maybe we will, when we go to the investigations, it will probably help you in differentiating. How does investigation help us in differentiating? We will discuss that out. Okay, next, what do you want? Let's go to the examination now. These were all on history. So anything positive on examination, because the time is short?
Sir, only thing was that patient had icterus and there was excoriation marks on his.
So, okay, there was excoriation marks, scratch marks, and Jaundice, that's it. Okay, let's go further. Anything positive on systemic examination?
Sir, abdomen was soft, liver was 13 to 14, liver span was 13 to 14 centimeter, no free fluid, no spleen, and the rest of the systemic examination was also no.
Okay, the question again here is before, what are your possibilities? And in addition to this, people are now asking, could it be you have kept your syndromic possibility as intrahepatic cholestasis, right? So could it be extrahepatic cholestasis also? So that is the first question. And why are you keeping intrahepatic as the only possibility? I can see it on the screen, not extrahepatic. And within intrahepatic, you have enumerated various possibilities. First, tell us why not extrahepatic?
Sir, this patient had a cholestatic hepatitis, the first episode, which was progressive and it resolved. So it's painless, progressive, and resolved of its own without any intervention. And then subsequently, there is no any history of pain abdomen, no history of any surgical intervention, no history of any gastric outlet obstruction or vomiting or any cholangitis or any past history of any surgical intervention. So points out towards intrahepatic etiology of the cholestatic jaundice. So we have
Dr. Setu Babu, Dr. Saraya, please.
Dr. Akash, would you have a difference of opinion with Aman?
Akash,
Sir,
you think extrahepatic could be a possibility?
Sir, based on history, I would still keep intrahepatic as the only possibility.
Okay. Dr. Saraya, your comments, please.
Yes, intrahepatic, I think.
And intrahepatic. Okay. So within intrahepatic, Aman, what are the possibilities? Any differences now or any addition or subtractions, what you said based on the history versus after examination? Are you changing your order?
Can an SOL in the liver present like this? Maybe a benign one, like a large cyst? We know hydrated cyst or intrahepatic cyst. We have actually a patient, maybe I'll send the X-ray to you. Large cyst causing, partial biliary obstruction, pressing on the duct, intrahepatic ducts. It just to expand. Once again, I repeat, it's only to expand our thinking.
Recurrent cholestatic jaundice in this patient, and then resolution, the interval between two episodes of span of 1 year, and in between symptom-free period and no prodromal symptom as such. So I think the presence of any extrahepatic was less likely in this patient on the basis of history and examination.
One more learning point, if only this patient had severe pain abdomen or a neck, your entire differential diagnosis jumps to new area altogether. Be careful about that. Fortunately, you did not have pain here. Yeah. Even a moderate pain would actually mirror another group of diagnosis altogether. From cholestasis, you move to severe cholangitis, not amounting to PSC-like syndrome. Maybe a stone, maybe a large cyst, sometimes lymph nodes rupturing into the CBD, and a hemobilia. These are some of the possibilities you need to think when pain is added. Keep a note on that.
Absolutely, I think I agree. So can we move further? So the question to you would be, I think Akash, maybe you can chip in now. How will you investigate? I mean, he has a possibility of PSC. It could be recurrent viral hepatitis, which is happening. BRIC is also a possibility. I don't think we should be considering PFIC because this is really not a progressive disease. Even the present episode is also settling down, right? The first had completely settled down. The second is also settling down. I would agree with the first three possibilities, but may not with the fourth. So with this in mind, how will you investigate and reach a, diagnosis?
Sir, I would like to see the complete blood count and LFTs and coagulagram of this patient.
Okay, we'll show you that. Yeah, so can you read and give your inference from here? So you have the first episode, which was happened in, 2019, went up to, March 2020, which was almost 4 months. And then the second episode, started somewhere in December and was ongoing till January, December when he came to us, but it was improving. So just infer this.
Yes, sir. So, sir, in all the investigations, we can see the complete blood count is almost normal with normal platelets. And in the LFTs, the patient had predominantly conjugated hyperbilirubinemia with one report of March 2020 showing normal enzymes, normal bilirubin and normal enzymes. In the liver enzymes, there has been high alphos, alkaline phosphatase have always been high, and we have 2 reports of GGT also, which is fairly normal, sir, and with synthetic functions are preserved in this patient. So we have conjugated hyperbilirubinemia with high alphos and normal GGT in this patient, sir.
So are you aware of an entity called, normal gamma GT or low gamma GT cholestasis? If yes, what are the causes of a normal gamma GT or low gamma GT cholestasis?
Yes, sir, we can have normal.
We have a poll question on this, sir.
Okay, we have a poll question. Okay, fine. So let's move further. So based on this, Aman, should we ask Akash to tell his possibilities, or we go to the poll question first?
We have a poll question here, sir.
So we go to the poll question. Okay, fine. So which of the following diseases are associated with jaundice and normal gamma GT except? So all except hoga, na? Okay. So PFIC1, BRIC, PFIC2 and PFIC3.
Was it Sunil who prepared the question?
Yeah, Sunil has prepared.
Yeah, I think if you are not very careful, let me, Aman and Akash, if you are not very careful, these are all negative questioning.
Yes.
Except all, but so you should be careful. People like me, tendency to answer is the nearest one, whichever is attractive. So be very, very specific and careful. Very dangerous examiner, Taneja.
So all always normal GTT except. Can you?
Except.
Okay. Maybe we can have the answer, what the audience is answering. Let's look at that first.
PFIC 3, 67%.
Okay.
PFIC 2, 9%. BRIC, 17%. PFIC, 7%. I expected BRIC to get much more scoring actually.
No, this is actually normal except, which means all would be normal gamma GT.
Hello.
There is only one which will have elevated GGT here.
Correct.
And the answer should be PFIC3.
Three.
Anything, Akash, your thoughts on this?
Yes, sir. I absolutely agree that PFIC3 is not associated with normal GGT, and rest all can have normal GGT, sir.
So the answer should have been PFIC3. Yes, we agree. Okay, fine. So can we move further?
Here, sir, just a quick summary of cholestasis, sure. And these are the causes, extrahepatic causes of raised GGT. And in intrahepatic also, you can have high GGT in mitochondrial disorders or beta oxidation, as well as disorders of the canalicular system. Low GGT is classically associated with PFIC and BRIC, and elevated GGT is seen in PFIC3, sir.
Neil, I thought of asking you particularly one question, pardon me. Such high bilirubin, do you attribute it to only one cause or some add-on cause? I mean, you were very uncomfortable, 60.
BRIC is
known,
yes, so BRIC is known to cause very high bilirubin and severe cholestasis. And sometimes, the treatment becomes very difficult. And in fact, people have undergone transplant for BRIC because of such incapacitating symptoms. So I think, sir, this remains a very strong possibility in this patient.
And you base this on liver biopsy as your, real.
Yes, sir.
Okay, so Akash, how will you further, Aman, maybe you can take it up. How will you further investigate and reach a conclusion? Because looks like this could be, one of the possibilities with cholestasis intrahepatic with normal gamma GT. So normal gamma GT, we said, the BRIC can be BRIC1 and BRIC2 also.
Yes.
And PFIC is also PFIC1, PFIC2. So since we are considering, are you considering PFIC1, PFIC2 here, or BRIC1 and BRIC2 here?
Sir, I'm considering only BRIC here because PFIC1 and 2 are usually seen in the younger age, and PFIC3 is already out on the basis of normal GGT. So I would like to keep BRIC1 and 2 both as my.
So both BRIC1 and 2. Okay, how will you further investigate?
Sir, just because of the predominantly cholestatic symptoms, I would like to see any cross-sectional imaging, and also because we had viral hepatitis with cholestasis as the possibility. So any viral markers if available, sir.
So the viral markers are all negative, and the autoimmune markers are also negative. Even the extended panel was negative. What next?
Sir, any cross-sectional imaging to rule out any overlap in this patient, sir?
Cross-sectional, okay. Can you read this ultrasound was normal, but can you read this MRCP for us?
So this is the MRCP film showing normal CBD till the lower end with the normal intrahepatic radicals which are not dilated, and so I think this is the normal.
We see extrahepatic bile ducts normal, but I'm not sure about intrahepatic left duct. Dekho thoda sa. Is that all right?
So I cannot see any beading strictures or.
Okay.
Any
Dr. Setu Babu, Dr. Saraya.
What is BRIC versus PSC in MRCP? What just 1, 2, 3 findings here, 1, 2, 3 findings. BRIC is almost normal.
Yes, sir.
So what happens in PSC? What are all MRCP changes that you can get? PSC is not a uniform disease. You can have a focal disease as well. So could you give me 4 variants possible in a PSC on MRCP?
Sir, we would see a dominant structure in case of a PSC. We can see pruning of the pruning of the intrahepatic radicals. We can see sir, beading appearance, and so these are the characteristic findings. We can find a dominant structure or a non-dominant structure also. We can have multiple strictures as well in the MRCP film. And
one more just to confuse you, there could be a higher percentage of gallstones in these people, which also Ajay, you should comment on.
Yeah, I think that was a question also, and somebody had commented. That's very important. Are there any differences per se related to gallstones between BRIC 1 and BRIC 2? Any idea on this? I think gallstones would be more common in BRIC 2. This is what my understanding is. And this entity known as LPAC also, low phosphorylated associated cholelithiasis, which again happens in younger people, gallstone associated, yeah, and that is associated cholestasis. That is also more common with BRIC 2. That is the other one. And then there's another entity, what is known as in PFIC3, what you can have is, the MDR3 deficiency gene, which is also associated with gallstones. So PFIC3 and BRIC 2 are more commonly associated with gallstones in comparison to BRIC 1, right? Okay. So I think, to me, I think this MRCP looks okay, except for this left duct, which was not very clear. So what will you do? Dr. Saraya, your comments on this?
I agree. In fact, there are few changes we can see in the left duct, and this can be a small duct PSC.
Yeah. Okay.
So can I point out here?
Yes,
as Akash said, there's no beading appearance, so that's why I rule out PSC.
Right.
Important that every disease will have a spectrum where this narrowing and beading appearance is an end stage disease, which is most classical. You won't be wrong if you observe and you say PSC, but every patient in PSC in evolution will not have beading appearance. So not only to look at end spectrum clinical features or end spectrum imaging features, it's good to look at the whole spectrum, as Dr. Setu Babu also said, that look at the whole spectrum rather than only end spectrum. At end spectrum, you are more right, you are more specific, but you are less sensitive.
Absolutely, yeah. And as rightly been pointed out, you can still have PSC and your larger ducts or your cholangiogram may be normal. And that's the entity, what we call it as small duct PSC. Yeah, absolutely. Okay, so what will you do now further?
With the so we can see some defect in the left hepatic duct. So I would like to go ahead with the liver biopsy, sir, in this patient.
Okay.
So can we take the poll question before that?
Okay, we'll take the poll question first. Okay. So what are the characteristic biopsy findings in BRIC? Periportal fibrosis, intracranicular cholestasis, Austin stain positivity, and neutrophilic infiltrates. Let's see.
There are some difference. I think this is 2 questions. Yogita, you have shown question 2. Case
question 2, I can see question 3 on my screen.
Go to question 2, sorry. Yeah, I think.
Which one you want to show, Dr. Which one you want to show?
The previous one.
Okay, so can you go back to the previous question?
Yogita, you have to change.
Yes. Yeah, this is the one.
It's still not moving still on my screen, but maybe any one of you can read it.
Yeah, I think it's still readings are coming.
Yeah.
And I think the answering now, I think people have slowed their pace now. From 77%, we moved to only 54% answering.
Okay.
Okay, we stop now and say the result. Yes. So the periportal fibrosis is 13%. Intracanalicular cholestasis is 68%. Arsine positivity 15%. Neutrophilic infiltrate 4%. I think intracanalicular cholestasis is the predominant finding.
Maybe
Aman,
Dr. you can, or any Aman or Akash, you can first comment, and maybe then Dr. Sunil can tell us the right answer.
So intracanalicular cholestasis we would find as the predominant finding in BRIC, sir.
Yes, I agree, sir.
Okay, fine. So can we move on?
The hepatocytes are very healthy. That's what.
Yeah.
We
Normal
always
finding.
talk about infiltration, which is probably not significant.
So this is the HND stain in low power field showing, sir, characteristic intracanalicular cholestasis with normal hepatocytes, sir. So we can see the portal tract with no any inflammatory infiltrate, which is not seen, sir, and normal hepatocytes, normal architecture with intracanalicular cholestasis, sir.
See, the differential, Akash was about the PSC versus BRIC, right? So I would be more interested if you tell me any bile duct changes, if at all you can see here, or any particular special stain you would like to do for bile ducts, because we need to look at the bile duct injury here, bile duct proliferation, bile duct injury, right? So and what we call the typical changes of pericholangitis and what happens in PSC. So are you commenting on that?
Sir, in the small duct PSC, we would find onion skin appearance in the bile duct, onion skin findings, as we cannot see any such finding, and we will also find some amount of fibrosis, which is again not seen here.
Okay, so I think the biopsy looked largely normal except for cholestasis, right? So I think there were no bile duct changes, if I can recall. But Sunil, you have any idea? There were any bile duct changes?
No, sir, it was normal.
It was normal, so there were no bile duct changes, right? Okay, so let's go further. So do we have the poll question or
Yes, sir.
Dr. Babu?
Yes, sir, a poll question.
Now, between is BRIC, which is diagnosed as benign, is it truly benign?
Yes, sir. Usually these patients, this is a benign disease, sir, and these patients do not usually progress to chronic liver disease.
Now, I want you to look at current literature where there are multiple case reports where BRIC has progressed to severe liver disease. Just go back and look at it.
Right.
It's not all that benign that we thought. I was also surprised when I read year back a few case reports. I think you should go to the Journal of Hepatology and recheck today itself. Is BRIC all that benign? Even I was thinking it's a benign and is not the whole truth. Okay, go to
Absolutely.
the question.
I think before we go to the poll question, there are 2-3 questions in the chat box. First is about the role of cytokeratin staining, which I was saying special staining for bile ducts in the liver biopsy. So what your comment on that? Second is people are talking about the threshold, or when would you do a biopsy in this kind of situation? First episode or second episode like this? And third is about the genetic testing or screening, with this kind of biopsy.
So special staining for bile ducts, definitely if you're considering a possibility of overlap, we should do that. And
so what cytokeratin stain do you do for bile ducts? So it's usually the CK7, right? CK7 staining we do, and that stains the bile ducts. So you can say about whether they are absent or what. I think CK7. And the genetic testing, the mutational studies which are there, So Dr.
Yes,
so I just wanted to introduce one more, which we were looking, is a vanishing bile duct syndrome. You need to know when, these are all overlaps, when we talk really. Some of these people, actually we saw during COVID period, some of them get a liver injury, which is similar to vanishing bile duct syndrome. Aman, Akash, you need to go back and again look at this entity, and you may have a question on this.
Sure. So let's go to the poll question. All of the following statements are true for break except at least 2 episodes of jaundice separated by a symptom-free interval, intense pruritus, elevated LFT with normal gamma GT, and progression to chronic liver disease. So all are true except.
Ajay, we need to close this.
We will close. I think this would be the
last.
This is the last poll question, and maybe Dr. Sunil would like to summarize maybe one approach to recurrent jaundice in few slides, and then we'll close here.
Oh, that should be fine. Yeah.
Yeah. So, are people polling for this, voting for this?
Progression to chronic liver disease 83%, elevated LFT with normal GGT 7%, intense pruritus 6%, 2 episodes of jaundice with symptom difference of short difference is 3%.
So most of the people would feel that it doesn't progress to chronic liver disease, but as pointed by Professor Setu Babu, that there are case reports where it has, worsened even the prick people. So I think, but in general, I think the perception is that this is benign and doesn't really progress on to chronic liver disease. Fine. So maybe I think the treatment is usually, is limited to ursodeoxycholic acid or maybe plasma exchange, where if they have very high values, or other antipruritic drugs, or the bile diversion, or even people have done NBD and various other modalities. Let's not go into the details on that. And even lastly, as Dr. Sunil pointed out, people have even been transplanted because of the this condition. So we can stop it here, and maybe I'll request Dr. Sunil Taneja to give us maybe a approach to recurrent jaundice in few slides. Or maybe before that, Dr. Setu Babu and Dr. Saraya, if they want to.
No, we'll ask Sunil to go ahead. We did enough of this.
Ajay, can you just for everybody to really understand? So the final diagnosis break in this patient?
Yes, final is break because of the 2-3, but he has 2 distinct episodes. This is the criteria which is required. Number 1, with a free interval was free of jaundice. That is 1. Secondly, it was a pruritus which was there, so cholestatic jaundice, high alkaline phosphatase, normal gamma GT.
And histology normal.
And histology normal. So that makes the case for break here. Whether it was break 1 or break 2, I think, as I said, short of gene mutations, it will not be possible for us to tell that. But since the absence of gallstones and various other things, and the break 1 being more common, I think we'll put more money on break 1 here.
And how was he treated over time?
He was treated with ursodeoxycholic acid. Luckily, he didn't require any plasma exchange or bile diversion treatment. And his second episode has also settled. Let me also give a message here that each episode of cholestasis can last for few weeks to even months in break. And the interval between different episodes can be again months to even years. People can have a second episode 5 years, 10 years later. So that interval can be variable, and each episode duration can be variable, but you must have 2 distinct episodes. But then the question which we always discuss in bedside is, how about a patient where the biopsy and everything is fitting into that, and he is presented for the first time? For example, if this patient had come for the first time to us, his MRCP would have been normal, his alk-phos was elevated, gamma GT was normal, his biopsy would have been normal, so he would still be break even if there was no second episode. So the second episode, you can say only when the second episode happens, and that may not happen for many, many years. So that would be the message we would like to give. So Dr. Sunil, you can go ahead, please, with the your approach. Yeah.
Yes, sir. So I'm going to skip this last question, and just to give you an overview, we've had a lengthy discussion on an approach to recurrent jaundice. So let's start with the approach to a patient with jaundice. I have just tried to simplify this. It can be either because of increased production of bilirubin or decreased clearance. And in decreased clearance, the causes can be related to the liver or to the extrahepatic biliary system. And increased production is primarily because of hemolysis, which can be either intravascular or an extravascular hemolysis. So this is the causes, list of causes of hemolysis. You can have non-immune causes, and hereditary are common, in which G6PD is the commonest. And you can have acquired causes like liver disease and hypersplenism. And then you also have immune causes of hemolysis, in which you have immune hemolytic anemias and PNH as common cause. So coming to the second one, decreased clearance, in which you can have either defects in transport and conjugation. And in this, you have Gilbert syndrome or Crigler-Najjar syndrome too, which can present in adulthood. In intrahepatic causes, either it can be a hepatitic illness, in which the common cause is viral hepatitis, AIH, alcohol-induced alcoholic hepatitis or alcoholic ACLF. And then you have drugs and toxins, and as well as cirrhosis can have a hepatitis and worsening like ACLF-like presentation. The second form is the cholestatic pattern, in which cholestatic form of viral hepatitis can be there, drug-induced, then PBC and PSC, and certain infiltrative disorders. IgG4 hepatopathy is an upcoming cause, and it's being diagnosed more and more. And as we discussed, genetic and familial causes like Brick, PFIC, and Dubin-Johnson and Rotor syndrome can also present with cholestasis. So moving on to the extrahepatic causes, primarily it is benign, and choledocholitis is one of the common cause. Then you can have biliary strictures, which can be related to chronic pancreatitis or surgeries, and then PSC, secondary sclerosing cholangitis, ischemic cholangiopathies, IgG4 cholangiopathy, and AIDS cholangiopathy are other uncommon causes. You have to keep in mind that malignancy is an important cause of extrahepatic cause of cholestasis. So how do you determine the pattern of liver injury? You can calculate the R value, which can be determined by a ratio of ALT upon the upper limit of normal to ALT divided by ALP divided by the upper limit of normal. And hepatocellular injury is if R is more than 5 and ALT is more than 2. Cholestatic injuries, R is between less than 2 and ALP is more than 2, and in mixed is if it is between the two. So moving on to how do you differentiate between intrahepatic and extrahepatic cholestasis? So in intrahepatic cholestasis, there will be history or presence of signs of hepatocellular failure like GI bleed, ascites, encephalopathy. There can be a temporal history of use of drugs which are known to cause cholestatic liver injury, like drugs like augmentin. And there will be history of prodrome if you have viral hepatitis with cholestatic phase. And as we have discussed, there can be a personal or family history of autoimmune diseases. And if the patient has been on TPN for a long time, they can have intrahepatic cholestasis. And if there is a history of liver biopsy in such patients, then you should consider that the cause likely would be intrahepatic. And extrahepatic, if there is a prior history of surgery, hepatobiliary surgery, if there's history of gallstone disease, and if there are features of cholangitis. Cholangitis forms a very important component of extrahepatic cause of cholestasis. And if there is fever, pain in the right hypochondrium, and along with that jaundice, then you should consider that it's a extrahepatic cause of cholestasis. And if there is a history of endoscopic or radiological biliary drainage, obviously you will think of extrahepatic causes, and then imaging would always help you in differentiating intrahepatic form and extrahepatic cause of cholestasis. And then in extrahepatic, again, you would like to differentiate between benign and malignant causes. Benign, obviously, the history would be long, and there would be history of sometimes recurrent biliary coli if there's gallstones. And if there is any history of surgery in the past, that might also suggest that there's a benign stricture there. And then obviously imaging can help you to differentiate between benign and malignant causes. If you consider malignant as a cause of extrahepatic cholestasis, then most of these patients would have severe constitutional symptoms. Advanced age would also favor malignant disease. If there is very deep jaundice, then obviously you should think of malignancy first. Presence of palpable mass and some relative points like GI bleed, gastric outlet obstruction, and ascites would also point toward malignant causes of extrahepatic biliary obstruction. So just to show you this final slide of approach to a recurrent jaundice patient, we have discussed that unconjugated hyperbilirubinemia can be an important cause, and you have to look for evidence of hemolysis in such patients. This can be done by looking at the hemoglobin, LDH, retic count. You can look at the peripheral smear and the plasma urine HP, as well as the haptoglobulin or the DCT test. And if there is evidence of hemolysis, then you can label that this unconjugated hyperbilirubinemia is because of hemolysis. And the common causes for this are vitamin B12 deficiency, autoimmune hemolytic anemias, drugs which can precipitate G6PD, it can be G6PD deficiency, which can be precipitated by drugs. Wilson disease and sickle cell crisis can also lead to hemolysis. The other entity which we have already discussed is Gilbert syndrome. And as Aman and Akasha pointed out, that unconjugated hyperbilirubinemia can worsen during stress and fasting state. And you can do a genetic testing to confirm the presence of Gilbert syndrome. The second part is if you have conjugated hyperbilirubinemia with increased enzymes, liver enzymes, predominantly AST and NT, and this would fit into an hepatitic-like illness. The common causes we have discussed include AIH, Hep B flare, alcoholic steatohepatitis, and sometimes pregnancy-related disease like hyperemesis gravidarum and ICP can also present like this. And the last is conjugated hyperbilirubinemia with raised alkaline phosphatase. And in this, we have discussed that PSC and overlap syndrome should be considered. But sometimes you can also have extrahepatic causes like choledocholithesis, periampullary carcinoma, relapsing pancreatitis, autoimmune pancreatitis, and IgG4 disease, which can present with recurrent jaundice. Lastly, we have discussed that normal AST-ALT with conjugated hyperbilirubinemia with gamma GT is how you make a diagnosis of BRIC along with the histology. So I think I can stop here.
So thank you, Dr. Sunil. I think we can hand over the stage now to Dr. Govind, but there's last comment which was there about some precipitating factors for BRIC, including some antibiotics, including amoxiclav combinations, which can be done. So that point is well taken. So Dr. Govind, maybe you can go ahead.
I think we can stop here. This is lunchtime. It's 1:30. Before we close, I'd like to thank both Akash and Amandeep for a wonderful case presentation. Two beautiful patients, two quite a different spectrum of a patient who come with recurrent jaundice. That's remarkable. And both of you did extremely well, very thoughtful and very lucid. Thank you very much and many congratulations to both of you doing so well. Coming to Dr. Saraya, Dr. Setu Babu, and Dr. Ajay Duseja, wonderful discussion. I think I learned a lot of points. I'm sure our fellow colleagues who participating in this case discussion must have learned a lot of important points. How do we approach a right way to approaching recurrent jaundice? Thank you so very much for taking us through these two cases. Quite learning experience. Dr. Sunil, you have been remarkable. Your summary slides of approach is very useful. And I request that if you can send this slide to Yogita and she can participate with all the participants, that will be the kind of ready corner on their phone that how do you approach recurrent jaundice. Thank you all so very much for participating. And more importantly, this was a very lively discussion. There were at least more than 150 questions by all our participants, meaning thereby, and I can infer from that all our many of our participants were actively involved in case discussion and sending very, very important questions. And Ajay, you just took almost every question into discussion. So that was very wonderful of all the participants in joining actively in the case discussion. We need to close this today's session, but before we close, we need to invite you for yet another session next week on next Sunday, and the topic will be cirrhosis with SCC and how do you approach and how do you make diagnosis, stage, and all other issues related with clinical medicine. Thank you, Yogita. Thank you, Dineshji and Manish for coordinating this program. Thank you so very much again. Have a good day. See you next week.
Thank you so much.
Thank you very much. Thank you. Bye-bye. Thank you.
Thank you, Ajay. Thanks for tolerating me.
No.
Thank you, sir.
Thank you.
You're going to stay. Dr. Setu, you want to stay?
Yeah, I want to just convey you a couple of messages.
And Dr. Rai also, sir. Sunil also, you also stay back.
Yeah, Ajay also.
I also stay back?
Yeah,
Yeah, you can.
Okay.
So I just had an observation.
Maybe people are still logged in. You want to have discussion?
No.
Everybody logs out?
I think the IT team should remove,
let others to log off. Yeah.
Man, you can log off